We call it RTA. Okay. Now, first thing, each renal tubular acidosis, each type. I know it's not easy, but you are expected to memorize what type. Because I see in an NBME, they just say the type 1, type 2, type 4. So you need to know which one is which, okay? So that's your task to memorize. Now, let's make it easy, folks. People make it so complicated, this renal tubular acidosis. We're going to make it simple. When we start, first one, I always like to start with type 2 because type 2 happens first, early in the kidney, because it's a disorder in the PCT, okay? So type 2 is in the PCT, proximal convoluted tubule. If I ask you, what is the exact problem of type 2 renal tubular acidosis? We are not able to absorb bicarbonate. That's it. We learn in physiology, most of the bicarbonate are reabsorbed in PCT, isn't it, folks? If you don't absorb bicarbonate, what happened? Bicarbonate is going in the urine. So your urine is alkaline, but your blood is acidotic. Is everybody clear, folks? That's it. That's the defect. Type 2 defect in PCT bicarb reabsorption. That's all it is, folks. Okay. If you remember that, then you will make up the rest. Urine is alkalosis, blood is acidotic. Is everybody clear, folks? Okay. Okay. Now, some people can ask me, even though the alkaline urine is coming, by the time they reached in collecting duct, they should be able to acidify because they secrete a lot of hydrogen, isn't it, folks? But still, that's not enough. You see, it says urine can be acidified by intercalated cells and collecting duct, but not enough to overcome the bicarb excretion. We excrete so much of bicarb that we cannot do that. Is everybody clear, folks? So the bottom line to learn type 2 renal tubular acidosis, we cannot reabsorb bicarb. Everybody clear, folks? Okay. Now, one example I can give you, Fanconi syndrome. Can you say Fanconi syndrome causes type 2 RTA? Yes or no? What is Fanconi syndrome? A defect in reabsorption in the PCT, right? So if you cannot reabsorb anything in PCT, which include your bicarb too, right? Technically, Fanconi can cause, folks. Multiple myeloma also causes. Why? Multiple myeloma shut down the PCT. Once you shut down, nothing works. Okay? Nothing works. Okay. There is a carbonic anhydrase inhibitor. Just remember this. When we do the pharmacology, that will make sense. I will explain that. Okay? So that's type 2. Is everybody clear, folks? Now we will go to type 1. Type 1 is a problem in the collecting duct. Okay? So it's a collecting duct problem that comes after PCT. Simply, we cannot excrete hydrogen. If you cannot excrete hydrogen, where do you keep the hydrogen? In the blood. So the blood is acidotic. Is everybody clear, folks? Okay, that's all it is. See, it doesn't matter whether it's a type 2 or type 1. At the end of the day, they are all giving metabolic acidosis. That's why it's called renal tubular acidosis. All these diseases give you metabolic acidosis, folks. Okay, metabolic acidosis. Is everybody clear, folks? Okay, that's metabolic acidosis. So to recap, type 2 is in the PCT. You cannot reabsorb bicarb. Type 1 is in the collecting duct that you cannot excrete hydrogen. So you keep all the hydrogen in the body that causes acidosis. Is everybody clear, folks? All right. Now let's compare that with the last one. This is pretty interesting. This is the only one that gives you hyperkalemia. This is the only one that has high potassium. The other two, if you see that, are low potassium. So I would remember that. So what's the problem here? Hypoaldosteronism or aldosterone resistance, which make perfect sense. Without aldosterone, can you excrete hydrogen? No. So you're keeping it in the blood, so acidosis. Without aldosterone, can you excrete potassium? No. You are keeping the potassium. That's why it gives you hyperkalemia. Is that clear, folks? That's why it gives you hyperkalemia, okay? So that's the idea. If you remember those 3 basic definitions, you would not have any problem in renal tubular acidosis. Okay, remember type 1, type 2, type 4, there is no type 3. There is, we don't need to learn. That's what it is, okay? So that's the idea. Type 1, type 2, type 4. Always, folks, okay? 100% one question in your NBME. Okay, so that's something important, folks. Now, you could ignore the rest. You don't need to worry about all these things. What they do in the exam, they give you the scenario. They want you to pick up what type. RTA1, RTA2, RTA3, all those things. So that's your renal tubular acidosis. Is everybody clear?
I understand type 1 and type 2, but type 4's mechanism is how?
Type 4, simply, your aldosterone is not there or aldosterone is not functioning. It's resistant. That's it. Okay, it's a hypoaldosteronism. That's all it is. Okay. Now, that concludes here. We will come to the pharmacology at the end. Let's go to reproductive, folks. Go to reproductive. Now, in reproductive, I only do high yield topics. High yield topics itself, it's a lot there. If you follow, because there's so much, you don't need to know all of them unnecessarily. If you follow all the topics that I cover in reproductive, you would not miss any question. Okay, so you have to be very careful with reproductive, because reproductive have changed in the last 4 years, completely different. There's so much of gynecology and obstetrics. Obstetrics has come in here, folks. Okay, so we're going to start in the middle somewhere, because I want that embryology to be understood properly. Go to this page, because if you don't understand this page, nothing will make sense. So I like to start from here, page 646. We're going to start with the origin of the fetus, and then we will move from different. So, okay, that's how you want to learn.
Am I losing my mind, or did we ever go over cardiopharm?
Did you guys watch the video?
Oh, right. But so was there a section before that we were supposed to go over, or no?
There is one section. I know there is one chart to cover
Okay.
it. I will cover it. Yes.
Okay.
There's two sections actually. I need to talk about fetal
Right.
circulation, and there's one graph that we skipped. We need to talk
Okay.
about. Yeah,
And then
yeah.
you're not going over the cardiopharm again?
I don't think so, unless
Okay.
you guys have this question.
Okay, great. Okay, thanks.
Okay. Now, sexual differentiation, folks. This is a very important chart. If you understand this chart, a lot of reproductive makes easy sense in here. Okay. Now, if you see here, let's start with XX. Okay. Now, when you see XX, they have ovary. Okay. Ovary produces estrogen and testosterone. Here, the most important is estrogen. So you should know, without ovary, there is no estrogen. It's important. Ovary produces estrogen. What that estrogen does, it stimulates external female genitalia. The estrogen can only help to develop external female genitalia. So that's your clitoris, labia. I want to highlight the distal part of the vagina. Okay, that's very important because there's a huge pathology, distal part. Okay, only the distal part comes from estrogen, where it's technically from ovary. Is everybody clear, folks? Okay, so that's ovary that does estrogen here, folks. I know the estrogen also responsible for breast development. These are secondary sexual characteristics. We'll come to that a little later. So ovary produces estrogen. Estrogen stimulate external female genitalia. Is everybody clear, folks? Then female also have something called Mullerian duct. That Mullerian duct is responsible for internal female genitalia. So external female genitalia from ovary, internal from Mullerian duct. Is everybody clear, folks? Now look at this, what Mullerian ducts develop. They develop fallopian tubes, uterus, highlight, proximal vagina. So we need Mullerian duct and ovary to develop the entire vagina. Is everybody clear, folks? So that's important here. Okay, so that's that. Now, one of the famous questions that comes on step 1. Patient mother brings her daughter because she's at the teenage age, but she never had menstruation. Okay, Now let's go back. I'm going away from that topic, but I have to go like this. There's something called amenorrhea. Amenorrhea means no menstruation. Is that clear, folks? There are two types of amenorrhea, primary and secondary. Primary mean this particular patient never had a menstruation. She never had menstruation. Secondary mean she had and then stopped. She had and stopped. So anytime we call it amenorrhea, primary and secondary. Primary mean never had it. Secondary had and stopped. So that tells us whenever patient says, I had menstruation without any problem for a few years, but in the last 6 months or 9 months, I don't have it. Mostly it's a hormonal problem, because if you have an anatomical problem, you would have never had it. Is that clear, folks? It's a hormonal problem or something. But if a question comes and if the patient says she never had menstruation, it's always a structural defect, okay? So, I mean, you could have hormonal, but hormone or structural defect. That's the idea here, folks. But at least secondary, we could rule out structural, because if she had a structural, she would have never had it. Is everybody clear, folks? Okay, so that's primary amenorrhea and secondary amenorrhea. Are we clear with this, folks? Okay, so now the question is, mother brings her daughter, she never had a menstruation. That means primary amenorrhea. During the physical exam, the physician noticed that her vagina is ending in a blind pouch. That word is important. The vagina is ending in a blind pouch, which means that patient only has distal vagina. She doesn't have proximal vagina. Is that clear, folks? The first question, what's the pathology? Or what's the answer? The answer is Mullerian agenesis. That means this patient never developed the Mullerian duct. The patient never developed the Mullerian duct, because without Mullerian duct, you cannot get proximal vagina. Is everybody clear, folks? So the vagina ending in a blind pouch, because when we do the pelvic exam, we cannot reach the proximal. It's not going. That means that's not developed. Is everybody clear, folks? Okay. That's your first question, Mullerian agenesis.
Dr. Roy, so always when there's a blind pouch, it's always a Mullerian duct issue?
Yep. Okay, so blind pouch, it's Mullerian agenesis. Okay, so you diagnosed it. Second question they ask, double step question. In this patient, which of the organs will be also absent? That will be fallopian tube and uterus. Because if the patient has Mullerian agenesis, not only proximal vagina, they would not develop fallopian tube, they would not develop uterus. Is that crystal clear, folks?
What exactly is the proximal vagina?
It's the first part of the vagina. So when you take the total vagina, we divide it into proximal, and the external part is the distal. Okay, so whatever the part that attached to the cervix, let's say the uterus, it's called proximal. Okay, so that's the idea here. So she would not have proximal vagina, uterus, and fallopian tube. Is that clear, folks? So that's the second step. Third step question. There was another question. Can this patient ever have a baby? Think and answer. The answer is yes. Surrogate pregnancy was the answer in that question. Why? She doesn't have uterus. Of course, she cannot carry the baby, but she has ovary to pick up the egg. Is that clear, folks? So she could take the egg. We could plant on somebody else's uterus, which we call surrogate pregnancy. That was the answer on that question. Okay. So we basically call renting some other uterus. Is everybody clear, folks? So that was the answer. Okay. So that's Mullerian duct. So you have to know what's Mullerian duct and what it does. Okay. Any question? All good with the ovary and Mullerian duct? Yeah. So that also tells you technically when a patient become, or not a patient, when a female become menopause. What is menopause? Menopause means ovary fails, isn't it, folks? Basically, your ovary is dead. It stopped functioning. When ovary fails, can you have estrogen, folks? No. So that tells you menopause patients have no estrogen. Does that make sense, folks? That is the biggest problem. So what is hormone replacement therapy in menopause? Actually replacing estrogen. Is that clear, folks? So that also brings you menopause, so you understand that. So that concludes this section, XX. Any question for me in there? All good? Okay, so that's XX. You see, XX looks complicated. So then the other side, there's XY, right? So that's a Y gene. Y gene carries, there's something called SRY in there, okay? So anytime you have a Y gene, we have testis, we develop testis. Testis has two types of cell, that's a must. Leydig cell and Sertoli cells. You cannot forget those things, folks, okay? Leydig cells and Sertoli cells. Leydig cells produces testosterone. Sertoli cells do not produce testosterone. Sometimes they ask you in a step 1 exam, literally which cell produces testosterone, and we don't know that. It's Leydig cells. Okay. Now let's talk about Leydig cells first. We produce testosterone, but the testosterone is not active form. Okay. Testosterone become active testosterone, what we call DHT, dihydrotestosterone, by an enzyme called 5-alpha reductase. That's your 5-alpha reductase. Is everybody clear, folks? That's your 5-alpha reductase. Very important because that linked to all the pharmacology here, folks. 5-alpha reductase convert the testosterone to DHT. The DHT is important to develop external male genitalia. The external male genitalias are penis, scrotum. Everybody knows that. People miss this. Highlight prostate. Because why? Technically, prostate is located inside of your body. So people think it belongs to internal, but it's not. It still belongs to external. Is everybody clear, folks? So prostate is part of your external male genitalia. When people comes with prostate enlargement, folks, what medication do we give? We give
Finasteride.
What is finasteride? Finasteride is 5-alpha reductase. Does that make sense, folks? Now you know when you give finasteride, we are inhibiting the 5-alpha reductase to make DHT. So that's why the prostate don't enlarge. Does that make sense, folks? That also tells you, is it safe to give finasteride to teenagers? Can you give? You shouldn't. Why? If teenagers take finasteride, that means they are blocking 5-alpha reductase. The external genitalia is not growing properly, folks. The penis, scrotum, and prostate won't develop properly. So now you should ask me a question, why would a teenager take finasteride, right? Because now it's a trend in the United States. Everybody wants to take finasteride for hair loss. Male pattern baldness is because of DHT. Does that make sense, folks? The biggest problem for hair loss is DHT. DHT attacks the hair follicles. So the only way to prevent that by taking finasteride. Does that make sense, folks? So, but you should never take it at teenagers, folks. We give it for prostate enlargement. Remember, these are 50, 60-year-old patients. The growth is already reached. They're not going to grow anything anymore. So that's why we stopped it. So that's something to keep in mind. Is everybody clear? So that's external male genitalia. Now on the other side, testosterone also help with the help of Wolffian duct. So male has Wolff duct, female has Mullerian duct. Don't confuse that. So the Wolffian ducts help to develop internal male genitalia. All these are internal male genitalia, folks. Seminal vesicle, epididymis, ejaculatory duct, ductus deferens, all this comes from that. You have to memorize it. You have no choice. Okay, that's internal male genitalia, folks.
I just didn't understand the relationship between finasteride and DHT. Like,
Oh, so DHT is the one that
Oh.
attacks the hair follicle. Okay, so that's why blocking finasteride blocks the 5-alpha reductase. So this will be reduced so they don't lose hair. Is that clear, folks? Okay. All right. Now, that's testosterone here and wolf duct. Is everybody clear? Now, another important thing to learn. If I have XY gene, I don't need Mullerian duct. Does that make sense, folks? So Sertoli cell secretes something called MIF. This is very important. That's called Mullerian inhibitory factor. So that factor goes all the way and block Mullerian inhibitory, it blocked the Mullerian duct. So these males don't end up getting internal female genitalia also. Is that clear, folks? There are medical conditions where they did not develop MIF. So what do you think will happen? Outside, they look like a male, but they will also have all the internal female structure. Is that clear, folks? Because the Wolffian duct is developing those. Okay, so that's that. So you have to know the basics, folks, here. Okay. Now, what
So
we
if,
have done so far is your primary sexual characteristic. These are called primary. From the beginning, what we develop is called primary sexual characteristic, folks. Okay, go ahead, Manikya.
So Dr. Roy, like if Mullerian duct and Wolffian duct both are absent, so there's no internal, or like which one causes absence of internal?
No,
Female gender.
you can't just say both are absent. Only Mullerian duct can be absent in female. So if you could simply say if Wolffian is absent, then they won't have any of the internal male genitalia. But there is no disease where the Wolffian ducts are absent. Maybe 1 in 5 million, but it's not something we want to learn. Okay, so the only thing you want to learn is if Mullerian duct is absent, that particular female will not develop any of those 3 structures.
And the relationship MIF, I always tend to miss these questions.
So if you are a male, if a male comes, if a testis develop, male doesn't need Mullerian ducts, do they? They don't. So that's why we inhibit the Mullerian duct by a factor called MIF. That's called Mullerian inhibitory factor. So when we become a male, we do not want Mullerian duct. If I don't inhibit the Mullerian duct, I would have proximal vagina, fallopian tube, and uterus. We don't want that. That's why anytime Sertoli cell comes into play, they want to make sure they inhibit the Mullerian duct. In other words, males shouldn't have a Mullerian duct. Is that clear? All right. So that's the differentiation here. You see, folks, this chart can ask so much question in development of organ. Now, talking about the secondary sexual characteristic. Wayne, you have a question?
Yeah, I just wanted to get clarification on the SRY gene. Like the point is just to say that will give us the Y chromosome.
That the Y chromosome carries the SRY, which gives you testis.
Oh, so can they ask about just like if you're missing an SRY gene on the Y?
No, they cannot. No. If you carry a Y, you have SRY.
Perfect. Thank you.
Okay.
I just have one more question. So for the male, they already have the Mullerian duct present, right?
Yes, they in the male
They
when
have
develop-
it.
Yeah, but need to be inhibited.
Okay. Okay.
Yeah, because remember, folks, every fetus, as the fertilization happen, they are designed to become a female. Is that clear, folks? And then the God says that we deserve something better, so we get the Y gene. Okay, so that's that.
So would the female have the Wolffian duct?
No, they don't.
All right.
Okay, so that's where we have the SRY gene that comes and inhibit the Mullerian duct, folks. Okay, so that's how it is. You know, this is important because when do you do a scanning to identify gender? You do it on the 20th week of gestation, isn't it, folks? So I'll just quickly do that. So ultrasound is done at 20th week of gestation to identify the gender of the baby, okay? But some parents or mothers cannot hold on to it. You could go pay out of pocket on a private place and you could do it on the 15th week. Okay. On 15th week, you could do ultrasound privately that cost about $400, and you could identify the gender, if they have to. Now, the problem with this, when you do the ultrasound on the 15th week, if they tell you it's a boy, then for sure it's a boy. Is that clear, folks? But if you do at 15th and they say it's a girl, you still have to do another ultrasound on the 20th week, because within that 5 weeks, you could turn into a boy. Is that clear, folks? It can turn into a boy. So that's why when you do at 15th, as long as they tell you it's boy, the money is worth it. But if they tell you it's girl, my wife wouldn't hold on to it. She wanted to go do it. I said, go do it. Use your card. I'm not paying for it. So she did it. And she goes, oh, they say it's a girl. I was like, very good. So now wait for 5 weeks, do it again, right? So because within that 5 weeks, that SRY gene can become active and inhibit that. Is that clear, folks? So that's why the hospitals always wait till 20th week of gestation to find out. Okay, so they always do it for the first kid, right? The first kid is the one that pampered with everything. Second one, they don't even do any ultrasound. If it comes, it comes. If it doesn't come, it doesn't come. So that's how the second kids, right? So anyway, so that's the idea here, folks. It's always 20th weeks. All right. So this structure, folks, if you understand, you see a lot of disease can ask, and you also understand why we have a problem with estrogen when we have menopause, because your ovary fails, right? That's the idea. So very important, folks. Okay. So with that, now let's go back to the previous page. They were talking about the disease that I talked here. You see, the Mullerian duct, right? This is that Mullerian agenesis. When you say Mullerian agenesis, these particular females do not have Mullerian duct. It's called that Mayer-Rokitansky-Hauser syndrome, whatever it is. It's primary amenorrhea, which means the patient never had menstruation because she doesn't have three structure. What are the three structure? Fallopian tube, uterus, and what else? Proximal vagina. Is that clear, folks? You cannot have menstruation without these things. Okay, so that's the idea. Look at this. Absent uterus, blind vaginal pouch, and then they have normal female external genitalia. They don't have a problem with that. Okay, and also secondary sexual characteristics. We're going to talk about that in a moment. But you guys understand Mullerian agenesis. Is that clear, folks? That's one of the high-yield topics. You need to know what is exactly Mullerian agenesis, folks. Now, if we go here, talk about secondary sexual characteristic. So what is secondary sexual characteristic? For female, it's basically breast development, pubic and axillary hair. That's done by estrogen. So you should know that. As long as you have an ovary, you are good with that. For male, secondary sexual characteristic is done by testosterone, folks. Okay. So for female estrogen, male testosterone. That's all you need to do. Is everybody clear, folks? Now you see, when we read Mullerian agenesis, they still have secondary sexual characteristic for those female because it's all about estrogen, nothing to do with Mullerian duct. Is that clear, folks? All right. Now I could ask you another question. If a patient has Leydig cell problem, let's say a male that has a defect in Leydig cells, can they get secondary sexual characteristic? They cannot, because there's no testosterone. Is that clear, folks? There's not testosterone, but they will develop the secondary sexual characteristics after puberty. Why is that? After puberty, your adrenal glands start producing some testosterone, dihydrotestosterone, folks. Okay, so they could help a little bit after puberty. So they will see the male until the puberty, not that much of growth, but after puberty, they will start having all those features, folks. Are we good with that? All right. So that's that, folks. Okay. Now, go to this page. Now here, they ask sometimes, I've seen this question, analog structures. A good example, there's a structure called genital tubercle embryologically, right? Genital tubercle gives glans penis in male, and in female it's gland clitoris. So they sometimes ask, what is the homologous structures for glans penis in female? That will be glans clitoris because they come from the same part. Is everybody clear, folks? right? So that's one. And I've seen a question they asked, where's the other one? This was the difficult one. They actually asked, what is the homologous structure for prostate gland in female? So what is the equivalent structure for prostate gland in female? These are called urethral or paraurethral gland. That's hard to remember, folks. Okay, so you should know that. And they could even ask you, the glans penis or glans clitoris, where do they come from? Genital tubercle. Same thing with urogenital sinus. I wouldn't memorize all of them, but at least this one, next one. Labor scrotum swelling, right? That gives you scrotum in male and labia majora in female. So technically, you would also see the nerve that innervates scrotum will be the same nerve that innervates labia majora, because physiologically they come from the same. So everybody clear for you? The sensation is the same too. So that's how that this chart, whatever I went through those three, I will do it. But if you want to memorize all of them, you can. So that's that. So everybody clear for you? All right. Now next, this congenital anomalies, folks. Okay, there's two diseases. Very important, hypospadiasis and epispadiasis. Now, before you learn that, we need to know what is the anatomical positioning of structure, right? So when I'm standing here, the anatomical position for the hand is keeping the hand like this. You have to be in this way. That's the anatomical position, not this way. Does that make sense? So that means in my hand, this is anterior, this is posterior. Is everybody clear for you? Same thing, when it comes to penis, there's an anatomical positioning, right? This is anterior, this is posterior. So the anatomical positioning is upward. That's how it needs to be placed, right? Very careful. So the anatomical positioning is upward. So this is anterior, this is posterior. Because if you don't know, when they ask you where the proctology, you will get the wrong side. Okay. People think hypospadiasis is a problem of most it's not. It's anterior. Look at that. Abnormal opening from the ventral surface, ventral meaning ventral meaning anterior. Is that clear? So there is an abnormal opening in the anterior surface. Why? Failure of irregular folds fuse. Yeah, it didn't fuse at that point. And most of the time, hypospadiasis comes with linguinal. Okay, it comes with linguinal. I met one patient of this disease. They have to go through 3 surgeries in a 3-month gap. So it's also like almost 9 months treatment. Okay, 3 surgeries in a 9-month gap. But at least you know there's surgery like that. So that's hypospadiasis. Are we clear? The next disease is epispadiasis. It's an abnormal posterior surface. Does that make sense? Because this is the position. Abnormal opening of the irregular dorsal surface due to faulty positioning of genital tubercle. So that should know pathology where what's the exact problem. Okay, so that's that. And this is always associated with bladder problem. So it's like hypospadiasis comes from the hernia. Epispadiasis comes with some bladder defect. Is that clear for you folks? So that's something to keep in mind. Okay, like that's disease. Now. So that's any questions on that? No. All right. This is I already talked about this kidney. I draw the similar picture. The key hemolysis. The right side goes to the right the testicular vein. This is called testicular vein. Testicular vein, the right side goes to the right to IVCC. Of the left side goes to renal vein and then to IVCC. Remember that's what we talked about the whole thing. That's why the varicose veins moment on the left side and all these things. Technically, there should be another vein coming here. That's renal vein. That's clear, folks. All right. So that's that. It's also a repetition, folks.
Dr. Roy, on the previous page, what did you say about these?
They have to go through 3 surgeries. Just interesting. But they need to have 3 surgeries to fix that. Yeah. Now, in this page, go to page 6550. Just tell that and you memorize this. They ask you that traveling you leave 4 5 options in from order you know the right order. It's a pure memorization. There's nothing to understand that. Okay. So that's now. Can you guys tell me that there is a disease? That particular disease has absence of vas deferens. Type it up if you know. Just checking. There's one disease that has absence of vas deferens. What's that disease? Cystic fibrosis. Okay. That is very important. One of the highest. We'll talk about this in the cystic fibrosis because if you see cystic fibrosis male is infertile. Okay. Infertile, they ask you why. They have no problem producing the sperm, but the sperm cannot travel because the structure is missing. Is that clear, folks? So they used to give a question. Which of the following is normal in cystic fibrosis? Spermatogenesis, they have no problem producing sperm, but they cannot travel. Is that clear, folks? Because there's a piece is missing on the bridge. That's what vas deferens. So here, just to remember, and when we talk about the outcomes. Okay. Now next is this one. There's something called genitourinary trauma. In that, this is one of the higher topic folks. Okay, urethral injury. There are two types of urethral injury: anterior and posterior. Okay, anterior and posterior. So we'll talk about that, and then I will come to your renal. You know what? Let's start from the top. Okay. So first, renal injury. Some people have the injury to the kidney, right? So they would have bruises, flank pain, hematuria. It's caused by a direct blow to the lower liver fractures. So whenever the rib on the lower fractures, it can poke the kidney. Okay, so that's kidney injury. And the next one, bladder injury, folks. Okay, urinary bladder injury. When you see a urinary bladder, there could be a few, right? It presents with hematuria. But remember, in the kidney is cast, here it's not cast. So it will be clear, folks. Okay. And some suprapubic pain, difficulty voiding, they have difficult to void. So there's a superior bladder wall injury. We call it dome on the top part, upper part. Direct trauma to the bladder, folks, like a seatbelt injury. Okay. Then we have anterior bladder wall or neck injury due to pelvic fracture. So that's the next one. Some bones and stuff can break, but it is not that common. It's not easy to get into, to break or have injury. It has to be a really bad trauma. Now let's go to urethral injury because this is a higher topic on the exam. Okay. Now if you see this picture, that's anterior, that's posterior. They both are a problem with urethra. Urethra is a structure that comes from urinary bladder all the way to the tip of the penis. Is that clear, folks, in males? Okay. Anterior urethral injury, posterior urethral injury. Look first, what difference do you see? Anterior urethral injury, there is something happening around the penis, whereas posterior, nothing is there. You see that, folks? Okay, so that's important. Even the scrotum, not only penis, even the scrotum. Okay, so that's something important where the problem is. So let's talk about this anterior. Anterior is a hernial straddle injury, disruption of bulbar urethra. They have what we call hematoma. What you see in the picture, it's hematoma, blood around the scrotum and blood around the penis. Those are called hematoma. The blood is accumulating there, folks. Okay, that's a hematoma. That's a hematoma. So that's anterior urethral injury. Now the posterior urethral injury, if you notice it before we read, nothing outside, everything is inside the lower pelvic cavity. You guys see that, folks? All inside. So let's see where that's a pelvic fracture. Underline Membranous urethra is the one that's damaged. I didn't highlight the bulb word. Did you see that? Because it's only membranous urethra is involved. So I want you guys to write it down. Membranous urethra. Membranous urethra is involved here, folks. Now that brings you to your question. Where is membranous urethra? Membranous urethra is basically after the prostate gland, before they enter the bulb. Is that clear, folks? That's membranous urethra. We're going to do a question that has a beautiful picture, then we will learn even better. Now here, the urine leak into the retropubic space and high riding prostate. So that's that, right? So how do you differentiate anterior versus posterior? Anterior, you have hematoma around the scrotum and the penis. There's an outside problem, whereas posterior is inside pelvic problem. Is that clear, folks? All right. While you